Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the ultimate USMLE Step 1 review. This is the second edition of the book, and we're going to go through it chapter by chapter. This is part 2 of the Dermatology chapter. We're going to be talking about pathology in this section. So let's start with common dermatologic conditions. Acne vulgaris. The formation of a comedone occurs in a 4-step process. 1. Hyperproduction of sebum within a sebaceous gland. 2. Formation of a plug blocking the pilosebaceous unit. 3. Inflammation reaction to Propionibacterium acnes, an anaerobic bacterium and a component of skin flora. And 4th, follicular wall rupture and spread of perifollicular inflammation. Sebum's exposure to air causes oxygenation of sebum and an open comedone or blackhead. Persistent occlusion leads to accumulation of sebum and a closed comedone, or a whitehead. Treatment often begins with topical retinoids and/or topical antibiotics, including benzoyl peroxide. Oral doxycycline or tetracycline may be used for moderate acne. Isotretinoin, or Accutane, is reserved for nodulocystic acne. Treatments for hormonal acne, which is characterized by flares related to menstrual cycles and a jawline distribution, include oral contraceptive pills and spironolactone. Now let's move on to rosacea. Clinically, and on the USMLE Step 1, your job often will be to distinguish this condition from acne vulgaris. Like acne, rosacea may cause red papules and pustules on the face. However, the age group is generally an easy clue for rosacea because it is more likely to occur de novo in patients older than 30 years, while it is rarer to see new onset acne in these patients. Distinguishing features also include telangiectasias, which blanch, rhinophyma, a bulbous erythematous nose, and a lack of comedones. A trigger is often associated with the condition. Such triggers include extreme temperatures or winds, strenuous exercise, severe sunburn, and certain foods such as alcohol, caffeinated beverages, and spicy foods. The usual treatment is with topical antibiotics such as metronidazole or oral antibiotics such as tetracyclines. In a patient older than 30 years with new onset papules and pustules with strong environmental triggers, think rosacea before acne vulgaris. The etiology of rosacea is unclear, but it is thought to be from a pathologic interaction between the innate immune system and skin microbes. Let's move on to lichen planus. These are inflammatory lesions of the skin of unknown etiology, but sometimes associated with hepatitis C infection. This condition is remembered and recognized by the 6 P's mnemonic: purple, polygonal, peritic, planar, plaques, and papules. Treatment usually involves high-potency topical steroids. It may be associated with Wickham striae, which are whitish lines visible in the papules, and the Kebner phenomenon, which are new lesions that appear along lines of trauma, usually in linear patterns after scratching. Let's move on to pityriasis rosea. This is thought to be secondary to a virus. This dermatologic condition may begin with a virus-like prodrome and a herald patch, a raised, oval, pink patch with central clearing. It appears on the trunk and may be confused with tinea corporis. The herald patch is followed 7 to 14 days later by multiple lesions similar in appearance but smaller. They form on the back and follow skin cleavage lines in a Christmas tree pattern. No treatment is necessary because the condition is usually self-limited. The characteristic morphologic pattern is described above, and the lack of scale found on the lesions can distinguish pityriasis rosea from tinea corporis. Keloids. These are firm, shiny nodules of scar tissue, type 1 collagen, as a result of granulation tissue, type 3 collagen, overgrowing the boundaries of a wound. Keloids overgrow the boundaries of the initial injury, unlike hypertrophic scars, which are raised scars that respect wound margins. Keloids are common in African American individuals. They classically arise over scars but can also develop at sites of piercings or tattoos. Contact dermatitis. a delayed type 4 hypersensitivity reaction in which contact with an allergen recruits previously sensitized T cells to initiate local inflammation. The sensitization can occur at any time after the initial exposure, even years later. Lesions are well circumscribed erythematous plaques that may have vesicles or bullae over the area of exposure. Common allergens include poison ivy, rubber, and nickel. Nickel can be found in jewelry and buttons, and the distribution of rash matches the area of contact. Treatment involves avoidance of the culprit allergen and topical steroids applied to any affected area. Systemic steroids may be needed in severe cases. After an exposure, contact dermatitis often takes days to develop. Consider a type 1 immunoglobulin E, or IgE, mediated reaction if development of a rash, often urticaria, immediately follows an exposure, such as with latex. Atopic dermatitis, or eczema, known as the itch that rashes, because symptoms begin as itching that erupts into an erythematous scaling lesion. Vesicles may present early, and lichenification occurs if the area is aggressively scratched. In adults, the distribution is in flexural areas, the antecubital and popliteal fossae, and on the hands. The face and body may be affected in children. The etiology involves an overlap between genetics, environment, and the immune system. The terms atopic march and atopic triad describe the other hypersensitivity comorbidities that patients may later develop: eczema, asthma, and allergic rhinitis. Treatment of eczema involves protecting the skin from excessive drying, avoiding irritants, and applying topical steroids and moisturizers or emollients. Urticaria, or hives. Pruritic wheals caused by mast cell degranulation, spilling histamines and other inflammatory mediators into the surrounding tissue. Acute urticaria, less than 6 weeks, is often secondary to an environmental allergy, whereas chronic urticaria is thought to be an autoimmune condition. Initial treatment is with second-generation H1 antagonists, or antihistamines. The lesions will be described as raised, erythematous, and intensely pruritic. Psoriasis. This disorder is caused by an interaction between the environment and genetics, HLA-B27, that causes a local inflammatory reaction and hastens the growth cycle of the epidermis, leading to thickened skin from keratinocyte accumulation in the stratum corneum at affected sites. Histology reveals hyperkeratosis and parakeratosis. Clinically, psoriasis presents as red papules with silvery scales that coalesce into well-defined plaques, often on extensor surfaces, such as the elbows and knees. Lesions may develop on sites of previous trauma, the Kebner phenomenon. Removal of the scale will reveal pinpoint bleeding, the Auspitz sign. Psoriasis can also affect nail beds in the form of pitting and joints in the form of psoriatic arthritis. Treatment of skin lesions involves topical steroids. Systemic steroids should be avoided because initial improvement is often followed by a rebound phenomenon upon tapering. Severe psoriasis may necessitate stronger agents such as methotrexate or tumor necrosis factor alpha inhibitors such as etanercept or infliximab. The rash of psoriasis is usually improved with sunlight exposure, and light therapy can also be therapeutic. Langerhans cell histiocytosis, or histiocytosis X. This is an abnormal proliferation of histiocytes. On the skin, this condition presents as red papules on the scalp or trunk that may display crusting or scaling. Painful osteolytic bone lesions of the skull are also characteristic. Lung nodules may also occur, accompanied by cough. Skin biopsy will reveal Langerhans cells, which are very large, about 4 times larger than a lymphocyte. Although this is a confusing disease that may affect many organ systems, on step 1 exam, the key diagnostic feature is often the presence of Burbeck granules on electron microscopy. These are tennis racket-shaped organelles within the cell. Let's now turn our attention to autoimmune diseases, starting with pemphigus vulgaris. This is a severe autoimmune bullous condition caused by IgG antibodies within the epidermis that attack desmosomes and lead to a loss of adhesion between keratinocytes, acantholysis. The clinical result is a formation of painful, superficial, flaccid, intraepidermal bullae. These bullae may expand on gentle stroking of normal-appearing adjacent skin, the Nikolsky sign, and may rupture, leading to painful erosions. Unlike with bullous pemphigoid, which we'll discuss later, there is frequently mucous membrane involvement. On the Step 1 exam, oral involvement of the disease is the most common clue that this represents pemphigus vulgaris and not bullous pemphigoid. Immunofluorescence reveals IgG deposits between keratinocytes. Treatment includes use of systemic steroids and supportive measures to maintain homeostasis. It is often treated like severe burn patients. Now let's talk about bullous pemphigoid. This is a less severe autoimmune condition in which antibodies attack hemidesmosomes, which connect epidermal basal cells to the basement membrane. Binding of complement leads to destruction of the basement membrane, separation of the dermo-epidermal junction, and the formation of subepidermal blisters. Clinically, this creates the appearance of tense bullae and subsequent erosions at the site of ruptured bullae. Bullous pemphigoid typically presents in older adults over the age of 60 years old, and unlike with pemphigus vulgaris, mucous membranes are rarely involved and Nikolsky sign is negative. The etiology of this condition is unknown, although it may be triggered by initiation of culprit medications. Bullous pemphigoid is relatively mild compared with other bullous diseases and often responds to topical steroids alone. There's a mnemonic. Antibodies in bullous pemphigoid line up below the basement membrane, and bullous pemphigoid is below pemphigus vulgaris in severity. Now let's shift our attention to conditions of pigmentation, starting with vitiligo. This is an autoimmune condition in which antibodies target melanocytes within the epidermis. The subsequent absence of melanin leads to depigmentation in flat, well-circumscribed macules or patches. This condition may occur in any race, but is more noticeable in dark-skinned individuals. Depigmented areas fluoresce under a Woods lamp, ultraviolet light, which can help detect depigmentation in light-skinned individuals. Vitiligo should not be confused with tinea versicolor, which causes hypopigmentation, not depigmentation. There's a key feature, and that is absent melanocytes. Albinism is an autosomal recessive inability to convert tyrosine into melanin, usually due to an inherited mutation in or deficiency of the tyrosinase enzyme. Patients have pale skin, white hair, and blue eyes. The risk for skin cancer is extremely high in these individuals. The key feature is decreased melanin. Now let's move on to solar lentigo. These are hyperpigmented patches seen in sun-exposed areas such as the face, chest, and arms, often seen in older patients who have had years of UV light exposure. They are also known as lentigo senilis and old age spots. Although these lesions are benign, they can develop into a type of melanoma known as lentigo maligna. The key feature here is increased melanocytes. Let's move on to melasma. Estrogen and progesterone stimulate melanocytes during pregnancy or oral contraceptive use to increase production of melanin. Hyperproduction of melanin causes formation of hyperpigmented macules and patches on sun-exposed areas. It's also known as the mask of pregnancy. This condition is only of cosmetic concern. Although it is much more commonly seen in women, men can also develop melasma. Treatment is with either makeup to darken the surrounding skin or topical hydroquinone to lighten the affected areas. The key feature here is increased melanin. The melanocytic nevus, or common mole. These are benign neoplasms of melanocytes that need no intervention. There are several different types, including junctional, intradermal, and compound nevi. These terms simply refer to their location in the skin. Junctional nevi are found at the junction between the epidermis and the dermis. Intradermal nevi are exclusively within the dermis, and compound nevi extend through both the dermal-epidermal junction and the dermis. And the key feature here is increased melanocytes. Ephilus is the common freckle. These contain normal numbers of melanocytes, but increased concentrations of melanin. The key feature here is increased melanin. Of clinical importance, freckles have similar histology to the café au lait spots of neurofibromatosis type 1. Now let's turn our attention to neoplasms, dysplasias, and malignancies, starting with basal cell carcinoma. This is the most common human malignancy. As the name implies, basal cell carcinomas develop in the stratium basale, often as a result of UV-induced DNA damage. Patients present with lesions on sun-exposed areas that are characteristically pearly nodules with rolled edges. Central ulceration and overlying telangiectasias also may be present. Diagnosis can be confirmed with biopsy, which reveals nests of basal cells demonstrating peripheral palisading. Basal cell carcinomas are treated with excision. The prognosis is extremely good because the risk of metastasis is vanishingly small. They are locally invasive, however. Actinic keratosis are precancerous dysplastic lesions characterized by excessive keratin buildup, forming crusty, scaly, rough papules and plaques. They tend to occur in sun-exposed areas such as the face and scalp, and may progress to squamous cell carcinoma. Diagnosis is based on physical exam, although lesions suspicious for squamous cell carcinoma should be biopsied. Actinic keratoses are usually treated with cryotherapy or topical 5-fluorouracil. Squamous cell carcinoma. Patients present with scaling plaques in sun-exposed areas. Histology reveals keratin pearls. Lesions are locally invasive and are more likely to metastasize than basal cell carcinomas. Risk factors include sun exposure, immunosuppression, arsenic exposure, and chronic draining sinus tracts, such as from osteomyelitis. Squamous cell carcinomas also have a tendency to grow on areas of scarring. An aggressive ulcerative squamous cell carcinoma that grows in an area of previous scarring or trauma is called a margolin ulcer. Erythroplasia of Queyrat is a specific term for squamous cell carcinoma in situ on the glans penis, usually secondary to infection with high-risk human papillomavirus serotypes 16 and 18. This subtype of squamous cell carcinoma tends to present as a velvety smooth red plaque. Keratoacanthoma. Controversially considered a subtype of squamous cell carcinoma, this lesion is rapidly growing and forms a dome with a central keratin plug. The lesion often grows so large so quickly that it outstrips its blood supply, necroses, and resolves with some scarring. Melanoma. A malignant tumor of melanocytes recognized clinically by the A, B, C, D, and E's. A for asymmetry, B for borders, which are irregular, C for color, or variance within the lesion, D, a diameter greater than 6 millimeters, and E for evolution, such as growing, changing color, or becoming pruritic. Melanomas are most likely to metastasize if they enter a vertical phase of growth. Therefore, depth of invasion is correlated with mortality. Their precursor lesion is the dysplastic nevus, which may display some of the above features and should be biopsied. This cancer has a positive S100 tumor marker, which is consistent with melanocytes' derivation from neural crest cells. While most melanomas are darkly pigmented, keep in mind that they can also lack this characteristic color and appear similar to the patient's skin tone. These are known as amelanotic melanomas. There are several types of melanoma. Superficial spreading melanoma, the most common type of melanoma. It undergoes radial or lateral growth before entering a vertical phase of growth, so the prognosis is good. Lentigo maligna melanoma. These develop from benign lentigos in sun-exposed areas. Acral lentiginous melanoma commonly occur on the palms and soles, although it can also occur under the nail. This type of melanoma is more common in dark-skinned individuals and is the least commonly observed type of melanoma overall. And finally, nodular melanoma, which enters a vertical phase of growth early on in its development with a poor prognosis. Now let's move on to seborrheic keratosis. Classically, a warty, stuck-on appearing lesion formed by a benign proliferation of keratinocytes. Seborrheic keratoses are tan to brown plaques and patches found on any part of the body. That is, they're not correlated with sun exposure. They are very common in older individuals, and patients tend to acquire more as they age. The development of seborrheic keratosis is believed to be an inherited trait. Plugs of keratin are visualized on histology, although these lesions need not be biopsied. Of note, the sign of Lacertre-Trellat refers to a paraneoplastic phenomenon with an eruptive presentation of multiple seborrheic keratoses, indicating an underlying malignancy, especially gastric adenocarcinoma. Now let's move on to vascular lesions, starting with cherry hemangioma. This is a benign proliferation of capillaries that forms a small red macule. They are more common with age and require no treatment. However, they will not involute on their own. Strawberry hemangioma is a benign vascular tumor that appears in the neonatal period and slowly involutes during childhood. No treatment is required unless it ulcerates or is near vital structures like the eye, in which case the child is treated with a beta blocker. There's a mnemonic, straw baby. Hemangioma occurs in childhood, while cherry hemangiomas develop later in life. Nevus flammeus is a vascular malformation consisting of dermal capillaries and postcapillary venules, also known as a port wine stain. They consist of blanchable, pink, red, or purple patches that are present at birth and do not regress, but usually grow with the child. Port wine stains are common on the face and usually do not cross the midline. They can be seen as part of Sturge-Weber syndrome. Pyogenic granuloma is a benign erythematous papule that grows quickly and bleeds easily with a distinctive collarette of scale. Pyogenic granulomas usually arise in young adults in sites of prior traumas, but can also develop in children and during pregnancy. They do not usually spontaneously regress. Angiosarcoma is a malignant proliferation of blood vessels or lymphatics, which classically arises in the breast, scalp, or face after prior radiation exposure. They are blue to purple macules, papules, or nodules that bleed or ulcerate. Treatment is with complete resection and adjuvant radiotherapy if radiation is not believed to be a causative factor. Now let's move on to skin infections and infestations, starting with cellulitis. This is an infection of deep dermal and subcutaneous tissue, often caused by Staphylococcus aureus or Streptococcus pyogenes. Infection is often from direct penetration of bacteria into the skin. Cellulitis presents as a streaky, painful, warm, erythematous, edematous lesion with or without fever. Because the infection is deep, the margins of the infection are typically not well defined, which separates this from erysipelas, a more superficial infection with more well-defined borders. Treatment is with antibiotics. Distinguish cellulitis from chronic venous stasis by the bilateral nature of venous stasis changes. Erysipelas. Similar to cellulitis, although infection is of the superficial dermis and lymphatics as opposed to deeper involvement. Erysipelas is more commonly occurs in children and those with impaired lymphatic drainage. Strep pyogenes is the most common pathogen. The lesion is well circumscribed with raised borders. Impetigo. Staph aureus, or less commonly Strep pyogenes infection of the face, which begins as vesicles and pustules that later rupture, producing the characteristic honey-colored crust. Bullous impetigo is similar, but the initial lesions are flaccid bullae filled with transparent yellow fluid. Of note, if the causative organism is Strep pyogenes, post-streptococcal glomerulonephritis is a potential complication, but not acute rheumatic fever, which only appears after Strep pyogenes pharyngitis. Post-streptococcal glomerulonephritis cannot be prevented with antibiotics, so treatment only affects the skin condition and does not prevent complications. Staphylococcal scalded skin syndrome, a severe and generalized form of bullous impetigo. Staph aureus skin infection produces exfoliative exotoxin, a protease that acts on desmoglein at the stratium granulosum to produce tense intraepidermal bullae, followed by flaky, non-scarring desquamation over the entire body. This condition occurs predominantly in neonates and is often accompanied by fever. Note that the desmoglein of desmosomes is a target in both staphylococcal scalded skin syndrome and pemphigus vulgaris. Necrotizing fasciitis. This is a flesh-eating, rapidly progressive infection of subcutaneous tissue, including fat and fascia, that spreads along fascial planes. The cause may be either polymicrobial or monomicrobial. Strep pyogenes is the most likely single organism. Necrotizing fasciitis often spreads from a site of local trauma or surgery. Clinically, it is similar to cellulitis, but is characterized by extreme pain, fever, induration, which is hardening of the skin, and skip lesions, non-continuous islands of infected tissue with sparing of intervening tissue. Sepsis is common. Treatment involves intravenous antibiotics and surgical debridement. Gas gangrene is a similar condition caused by infection with Clostridium perfringens. In this infection, crepitus, crackling sensation on palpation, may also result from gas production by the pathogen. Now let's move on to dermatophytes. These are superficial fungal infections of the skin or nails in which the fungus survives by metabolizing keratin. These infections are caused by epidermophyton, microsporum, and trichophyton species. Infections are named for their location on the body. For example, tinea capitis on the head, tinea pedis on the foot, tinea corporis on the body, and tinea cruris on the groin. Tinea corporis presents as a raised, erythematous, oval ringworm. There is characteristic trailing scale, which describes scale in the center of the lesion, but not on the border. This feature can be used to distinguish tinea corporis from the herald patch of Psoriasis rosea. Potassium hydroxide prep on microscopy can be confirmatory by demonstrating the presence of hyphae. Tinea pedis can present with scale along the sides of the feet in a moccasin pattern and can involve the nails, known as onychomycosis. Look for cracking between the toes, which can serve as a point of entry for bacteria and result in a superimposed cellulitis. Treatment is with topical antifungals, except onychomycosis, which requires systemic antifungals due to poor absorption of topicals through the nail. Topical steroids should be avoided because they can exacerbate the infection. Tinea versicolor. This is a superficial fungal infection with Malassezia globosa or Malassezia furfur that causes hypopigmented or hyperpigmented macules and patches with possible associated scaling. Lesions generally occur on the trunk and arms. Patients will note that it seems to get worse in the summer, which is usually due to sun-induced hyperpigmentation of surrounding normal skin, making the hypopigmented tinea versicolor lesions look even lighter. Potassium hydroxide prep reveals the spaghetti and meatballs appearance of the hyphae and yeast, respectively. Scabies is a superficial infection with the parasite Sarcoptes scabii, which burrows into the skin to live and reproduce. The mite is spread through person-to-person contact. The most profound feature of scabies is severe pruritus caused by a delayed type 4 hypersensitivity reaction to the mites, their eggs, and their feces. The rash usually consists of erythematous papules with secondary excoriations. However, the burrow is pathognomonic and appears as a thin raised line along the skin. Crusted scabies, formerly called Norwegian scabies, is a severe infestation that is associated with immunosuppression, such as from AIDS. Mineral oil prep may be confirmatory by direct visualization of the mites or eggs. Topical permethrin is the initial treatment of choice, and systemic ivermectin is used in severe or refractory cases. Oral hairy leukoplakia. These are white, hairy plaques found on the side of the tongue caused by opportunistic infection of Epstein-Barr virus. The presence of leukoplakia should be concerning for HIV infection. This lesion can be distinguished from thrush and oral candidiasis, which is caused by Candida albicans, because leukoplakia cannot be scraped off easily and tends to occur on the sides of the tongue. Oral candidiasis can occur in both immunocompetent and immunocompromised individuals. Esophageal candidiasis, on the other hand, is highly concerning for immunosuppression and is considered an AIDS-defining illness. Leukoplakia. This is a white patch on the tongue or oral mucosa secondary to squamous hyperplasia. Like oral hairy leukoplakia, this lesion will not scrape off. It is considered precancerous because some cases may progress to squamous cell carcinoma. It is highly associated with tobacco use, especially smokeless tobacco. Treatment is with cessation of any carcinogenic habits and/or surgical removal. And finally, verrucae, or warts. This is a viral infection with human papillomavirus, or HPV, causing acanthosis and hyperkeratosis. As in cervical infections with HPV, cells with enlarged irregular nuclei, coilocytes, are present. Treatment is with cryotherapy. Verruca vulgaris is a common wart, often found on the hand. This presents as a raised, rough papule. Verruca plantaris is a smooth, flat wart, often found on the sole of the foot. Pinpoint bleeding is often present. And condyloma acuminatum. These are genital warts caused by HPV subtypes 6 and 11, which are low-risk strains. That's the end of this section, part 2 of the dermatology chapter. In the next episode, we'll be talking about dermatologic manifestations of internal disease and pharmacology.